Have y'all ever read a paper on a topic that you're really interested in? One that asks exactly the clinical question you've been dying to know for years. You're looking for a difference that you so hope will be there, and you finally found the paper that looks like it'll answer it. You sit down to read the paper, maybe even with a tasty glass of your favorite adult beverage. And you see some small sample sizes, but an apparent difference favoring your drug of choice. Things are getting exciting, but then you get to the p-value and you see that it is greater than 0.05. Sad, sad trombone sounds. Man, I know it. That's a terrible feeling. You were just so close. But rules are rules. P-values of greater than 0.05 clearly mean that the difference is not statistically significant. The textbooks say you can't reject the null hypothesis, and let's face it, the null hypothesis, that's about the only thing you remember from that damn stats class you were forced to take so many years ago. That null hypothesis, that's the thing that says there's no difference between the two drugs. The only hope now that this trial has been a failure, the only hope is that another better powered study comes along in the future that maybe shows a difference. Or, maybe a systematic review and meta-analysis that incorporates the blah, 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 blah. But, in the meantime, you can't do much more than finish that tasty beverage while dreaming the sweet, sweet dreams of future studies. It's all you can do, right? Right? But you might be saying, hasn't Jarvis been going on lately about some other approach to statistics? Maybe something Bayesian or Basian or something like that. Is it possible maybe that could help us? Well, I'll tell you what, we have a paper that is hot off the presses, and it brings us to this exact situation. It compares adenosine to diltiazem for the treatment of SVT, something that I am really interested in. And it has, unfortunately, that dreaded p-value, specifically at 0.08. So clearly, there's nothing we can learn from this trial. But is it possible that we can resuscitate these results into something we can use? Well, stick around. We'll dive right in and find out.
Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice, and maybe stumble into a bit of nerdery along the way. But before we dive in, I have a couple of disclosures to make here. The first one is that I have fairly strong feelings about which of the two treatments discussed in this paper that we should be using first, but more about that later. Next, I want to let y'all know that I'm trying something different for this episode. I've been using generative AI a lot lately to generate cartoon images for my presentation slides or for YouTube videos. I also use it extensively to help me debug data analyses. In fact, I would say that ChatGPT has been an absolute godsend in speeding up my analyses and helping me troubleshoot it. It's truly amazing for that. But so far anyway, I have steadfastly refused to use it to help me write anything. My mother and my grandmother were English teachers, and I have always taken pride in my writing. And if I'm being honest, I kind of feared disappointing them by using a machine to do what they worked so hard to teach me how to do. And because I'm a science fiction nerd at heart, I'm secretly worried about what a future Sarah Connor might think about my use of AI. But developing a theme and scripting out these podcasts takes a long time. I've heard others say that they upload samples of their writing and then they ask ChatGPT to write something that matches their style. They give it a rough outline and they say, "This is my style, go forth and write." So I figured I was going to give it a try. So I uploaded the scripts of the last 6 episodes, and after some back and forth, it produced something that I could at least work with. Now, I'll be honest, it wasn't great, but it was okay. It was fine. It was a good start. Now, as it turns out, I rewrote almost all of Chat's writing, but editing what has already been written is way easier than writing initially. So much easier. So I'll be honest, I'm not sure if it actually saved me any time, which was the whole point of this exercise. And I don't know that I'm going to do it again, but I figured I'd give it a try. And because all the journals are asking you to disclose if you're using generative AI, I figured I should probably, disclose that I'm using generative AI. Now, I'm glad that we have that out of the way. Let's dive in. So the paper for today is by TCU med student Catherine Lee and has several other TCU med students as co-authors. There are also some EM faculty members from the group that I work with here in Fort Worth, including my colleagues at Baylor Scott & White in Fort Worth, Drs. Drew Shedd and Eric Chao. Great job on this paper, y'all. It was truly a pleasure to read. I really enjoyed it. And I hope you'll bear with me because I'm going to use it as an opportunity to discuss something else about research that I've been thinking a lot about lately and I really want to get into. So the title for this paper is Adenosine versus Fixed Dose Intravenous Bolus Diltiazem on Reversing Supraventricular Tachycardia in the Emergency Department, a Multi-Center Cohort Study. Now, as usual, we'll start describing the paper with the PICO question. The population, well, it was adult patients presenting to an emergency department with stable supraventricular tachycardia. Stability here, they defined as patients without hypotension or other signs of end organ damage. Now, the intervention and comparison, those were the initial treatments administered. They compared initial adenosine at any dose compared to initial diltiazem at any dose, but given as a bolus. So they did not include infusions here. And obviously, there were no adenosine infusions. They allowed subsequent medications following the failure of an initial agent. So if they gave adenosine and needed to convert to a different drug, they included that, but they analyzed them based on the initial medication. Now, the primary outcome was conversion to a sinus rhythm within 30 minutes of the initial drug administration. And secondary outcomes included conversion at several intermediate times, including 1 minute, 2 minutes, 5 minutes, 10 minutes, and 20 minutes. Now, they also compared the time to conversion as a continuous variable, and they talked about some adverse events, but those really weren't predefined outcomes. Now, put together, the clinical question is this. In stable adult patients presenting to the emergency department with SVT, what is the association between initial treatment with either adenosine or diltiazem and conversion to a sinus rhythm within 30 minutes? Now, to put things in frequentist terms, which is the analysis approach they used here, like the vast majority of science, and if you don't know what frequentist statistics are, don't worry, that's just what you probably call statistics. Well, in those terms, their null hypothesis, which you have to have, core point of frequentist statistics, well, their null hypothesis was presumably that there is no difference between the rates of conversion between additional adenosine or diltiazem. Now, as a reminder, in frequentist stats land, significance requires there to be at least a 5% probability of seeing as large or larger results as are seen in this trial, assuming that the null hypothesis is true. Now, I know that's a mouthful. It sounds like blah, 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 blah. What the hell does he mean? Just show me a p-value greater than 0.5, and then I'll know it's true. I know it's wordy, but it turns out that's what those pesky p-values mean. The way it's commonly used in the clinical world, it's pretty much p-value greater than 0.05 means no significant results. And that's just a bummer for those studies that have a p-value of 0.049. I mean, they were so close. But that's just the way the frequentist cookie crumbles. So this study. This was a retrospective multi-center cohort study involving 344 patients treated at one of 5 Baylor Scott & White emergency departments in North Central Texas. Now, just full disclosure here, I work at one of these facilities, so I wasn't involved in the study. Actually, for all I know, one of my patients was involved in the study, but I didn't participate in the study. So they went in and identified cases by searching Epic for ICD-10 codes. In case you're wondering, the Rangers and the Padres are just about to start. My phone just had to interrupt us with that breaking information. So identified cases. How'd they do that? Well, by searching Epic for ICD-10 diagnoses related to SVT. They used a structured abstraction process, including predefined definitions, and they talked about their clear process for resolving abstraction discrepancies. They nicely describe how they abstracted the data, and that's important, and it's something that most papers don't do. So good job, y'all. Now, they do report baseline characteristics, the differences in the baseline patients who got adenosine and diltiazem, but they only performed an unadjusted analysis, which doesn't attempt to mitigate potentially confounding differences. If they'd wanted to try to do that, which I think they should have, they could have used a multivariable logistic regression or maybe propensity matching. Instead, they used Fisher's exact test for the primary outcome. Now, as an aside here, typically for categorical outcomes, if we're going to do just a raw comparison, we're going to use a chi-square test. So why'd they use a Fisher's exact test instead? Boy, am I glad you asked. Fisher's exact is helpful when you have small sample sizes or when the cell counts in contingency tables are very low. And I mean really low, as in less than 5 low. Now, chi-square can give you a result in these cases, but it's likely to be inaccurate. Fisher's exact test, on the other hand, now it may burn way more CPU power, but it gives you more accurate results. I have a cat. The cat really feels the need to muck with my soundboard and come and join us in the conversation. Cats notwithstanding, where were we? We were talking about Fisher's exact test and CPU power. Well, honestly, it doesn't really matter about CPU power anymore because the processors we have today, oh my God, are they powerful. You can pretty much do, this cat is really distracting me. So Fisher's, perfectly appropriate thing to use here. So they, really, cat? Nova? What do you think about using a Fisher's exact instead of a chi-square? Do you have problems with that? I don't think Nova really has thoughts on Fisher's. She seems to be very oblivious to Fisher's test. What? Oh, she says she's really a fan of chi-square. And oh, yes, I agree. They probably should have done a multivariable analysis, but they didn't. Can we get on? Do you mind if I get back to the episode? Yes, the cat cares, apparently. So where were we? Oh, yeah. So one other thing that that I seem to be very distracted about. Damn it, cat. So how did they report their results? So they report them in terms of p-values. Now, I got my academic ass handed to me the first time I submitted a paper to Annals of Emergency Medicine where I was reporting p-values only. Now, my conclusion at the time, because it was painful, after getting over the deep sense of worthlessness, of despair, the need to drown my sorrows in bourbon, that if we're going to be honest, I usually get every time I read peer reviews on my paper. But in this case, what I realized is they were actually right. Having seen the light on p-values, what I like instead is an absolute difference and a 95% confidence intervals. And I think they're just much more informative. If you're going to use a regression model, you can report odds ratios or risk ratios or hazard ratios with confidence intervals. Those things are all better than p-values. Now, my mantra has been down with p-values, and I may have even made some EMS Lighthouse Project merch with that slogan on it. So I kind of sort of felt like I had to mention it here. So let's get on with the cat is going to have to go. So say hello to the cat and goodbye to the cat. Thank you, Nova. Where were we? We were talking about results. So overall, they included 344 patients. About 90% of those, well, 90 exactly, 310 patients, got first-line adenosine, just like good little AHA robots. The remaining 10% got diltiazem. Now, there were some important differences in baseline characteristics. Things that jumped out to me were the median age with adenosine was 56 versus 12 years older, 68 with diltiazem. And the initial heart rate in those who were treated with adenosine was 168, kind of what I would expect with an SVT. But in the diltiazem group, it was only 133. Now, that heart rate difference, that was kind of striking to me. I typically expect to see rates between 160 and 220 in adults with SVT who aren't on some type of oral rate blocking agents, things like beta blockers or maybe even calcium channel blockers. Now, they didn't report the proportion of patients in each group who are on those medications, so I'm honestly not sure what to make of this difference. Now, they did, however, do a great job describing the pre-existing medical history, and it turns out the diltiazem group had more than twice the rate of cancer history. Now, I don't know what to do with that either, because as far as I know, cancer doesn't predispose you to SVT. Now, these differences could certainly impact the effectiveness of medications, but mostly they just suggest an indication bias to me. This was a cohort study, after all, where treatment was not dictated by the needs of the study. So the treatment then was chosen by the emergency physician, and I'm guessing they had a reason for choosing what they did, and the patient type may have had something to do with it. Just one other thing to ponder here, and one other reason that maybe logistic regression would have been better. Now, nitpicking out of the way, the bottom line results are, in my opinion, almost certainly correct and most likely reproducible. And I don't just say that because, well, it's what I wanted to see. I say that because there's other literature that is consistent with this. It finds similar results, including some randomized controlled trials. All right, so bottom line, what'd they find? Well, 66.8% of the patients treated initially with adenosine had converted to a sinus rhythm within 30 minutes, compared to 82.4% with diltiazem. Now, they don't report it, but simple math here says that is a 15.6% absolute difference that favors diltiazem. Completely consistent with my priors. It's great news. It confirms my biases. This is absolutely my favorite type of research results. But this is a frequentist analysis, so I have to suppress that glee and wait for the all-important p-value, which was, drumroll please, 0.08, meaning not statistically significant, meaning we can't reject the null hypothesis of no difference. Well, crap, that sucks. I really wanted to see diltiazem proven to be the better drug. Now, before I go completely off the rails with my predictable diversion into Bayesian rambling, let me just say that the authors, I think they handled this result very well. They noted the statistical results may just be from the results of a small sample size or maybe from not using an adjusted model. And they very reasonably point out that even if you're using full Monty frequentist interpretation, it suggests that there's no difference between agents. And given the truly crappy way that adenosine makes patients feel, equivalent results here suggest you should at least consider diltiazem. Now, they did dig deeper into several other aspects of their data, including subpopulations with underlying atrial fibrillation that was exposed by the initial treatment. Now, what do I mean by that? When AFib, we all know, irregular, but when it gets going really fast, I don't care how irregular your rhythm is, at 180, it seems pretty damn regular. So when you slow a rhythm down, at least transiently, you can see what's underneath there. And they took a look and described that population that had that exposed AFib or A-flutter. They also dove into patients who got combinations of different medications. That's all interesting, but I think it takes away from the bottom line, which is this 15.6% improved conversion with diltiazem that wasn't statistically significant. They did the right thing here. They claimed no difference because of the p-value of 0.008. And that's what you have to do after jumping in for a swim in a frequentist pool. You gotta play by the rules of the pool that you jump into, after all. But it does leave us with nothing to make clinical decisions with. It's frustrating, and it doesn't really reflect the way clinicians think about problems. I mean, seriously, how many of you, when faced with two potential treatments, how many of you have asked yourself a damn thing having anything to do with rejecting a null hypothesis? I'm guessing none of you have. And for that one person out there saying you wake up in the morning thinking nothing about null hypotheses, well, you're even more of a nerd than I am. And Lord knows I need nerd counseling. I hate to think about what that means for you. Now, on the other hand, for you normies out there, how many of you are asking yourself, what is the likelihood that drug A is better for this condition and this patient than drug B? And I'm guessing that's most of y'all. And the only way to answer that type of question, the question that we actually ask ourselves, is with a Bayesian approach. So let's all raise a glass right now to Thomas Bayes and get our nerd on. When I finished paramedic school in 1988, the only therapy we had for SVT other than electricity was verapamil. And as y'all likely know, verapamil is another non-dihydropyridine calcium channel blocker like diltiazem, but maybe with a little less hypotension. You see, we didn't have adenosine back then. Or for that matter, we didn't have glucometries or pulse oximetry. We were still giving thiamine before glucose for every patient, for God's sakes. If we needed to secure the airway, we used EOAs and EGTAs for our rescue devices, and everybody got 2 large bore IVs of lactated ringers and mass trousers. We used the world's best monitor defibrillator, the LifePak 5, and I will fight you on that. Don't argue with me on this. It was amazing. And then, we called for orders with an APCOR radio, and we carried all of our goodies in a Plano 747 case. Those were good times. They were dark ages, I got to tell you. It turns out none of that shit was working. Maybe the Plano case carried our drugs. My shoulder still hurts from carrying it, though. But I digress. Verapamil worked. That's the bottom line. But it turns out adenosine was shiny and it was new, and it suddenly became recommended by ACLS. It worked really, really quickly when it worked, but it had this nasty side effect of making patients feel like absolute dog shit. They got chest pain. They felt like they were going to die. 0 out of 10, they most certainly did not recommend. Now, in general, I prefer to not hurt my patients. And because I found that purely anecdotally, mind you, diltiazem works as good or better than adenosine, and it doesn't cause more hypotension, and it doesn't make them feel like crap, well, I prefer diltiazem as my go-to drug, and my EMS protocols do the same. We go straight to diltiazem for adults with SVT. And we do the same thing, for that matter, for narrow complex atrial fibrillation or atrial flutter with RVR. So that's my bias here. I just want y'all to know that. Consider it fully disclosed. So as a good Basian wannabe, I'm not starting from a neutral position here. I'm inclined to believe that diltiazem is at least as good as, if not better than, adenosine. But I still want to see the data, and I want to see the statistics support that belief. So let's do a quick refresher on how frequentist statistics differs from Bayesian approaches. So in frequentist statistics, we often start with a null hypothesis. For example, that there is no difference in effectiveness between adenosine and diltiazem. We then calculate a p-value, which tells us the probability of observing data at least as extreme as what we saw, assuming that the null hypothesis is true. And if this all-important p-value is below a pre-specified threshold, which we all know is carved in stone, Moses himself handed it down, it said it shall be less than 0.05. If it is, then we can reject the null hypothesis and say the result is statistically significant and get our paper published. Now, in this study, the p-value was 0.08, which means the data did not meet the conventional cutoff for significance. Moses was not happy. But this doesn't mean there is no effect. It just means that the data are not strong enough to confidently reject the null hypothesis under frequentist rules. And if we're being purist, which I got to say very few of us are, it means we have to wait for another study and just not make anything out of the data we have. Now, in contrast to obsessing about statistical significance and null hypotheses, Bayesians combine prior evidence-based beliefs with new data to produce a posterior probability. And it turns out it doesn't matter how big or little that data is, you can always use additional data. And what it creates is this posterior probability or post-test probability. And that's a distribution that reflects what we believe after seeing the data. Now, to help me make this point, I asked ChatGPT to do a quick back-of-the-envelope Bayesian reanalysis using the summary data reported in this paper. Why did I do that? Well, because I could. Of course, I mean, that seems like the best reason. I wanted to get an idea of what the probability is of at least seeing the minimum clinically important difference in conversion rates given these results if we're assuming a neutral prior, which means a 50-50 guess as to which drug is better. Now, that's not what my priors are, as we've already talked about, but for the sake of argument, I wanted to see what the results would be, discounting the prior literature, so starting with neutrals. Now, unfortunately, there is no published evidence that I can find that tries to define the MCID, minimum clinically important difference, for this question about SVT conversion. So I did what I typically do in these situations. I consulted the wisdom of the guild, that is my friends, my trusted EMS physician colleagues, and asked them what the MCID here should be. And the guild agreed that a 5% absolute improvement in conversion rates would be clinically meaningful, certainly enough to influence practice. So I asked Chat, my buddy Chat, to calculate the probability, again assuming neutral priors and given the summary data in this table, that we would see at least a 5% absolute improvement in conversion rates with diltiazem compared with adenosine. Well, what did we find? Well, certainly not anything to do with statistical significance or p-values. Instead, we found something I find much more actionable. There is, according to this back-of-the-envelope math, an 89.2% probability that diltiazem improves conversion by 5% or more within 30 minutes. Now, what was Chat's conclusion? Well, Chat had a little bit of an attitude here, he said. That's right. Even though the frequentists said not significant, the Basians say that there's almost a 9 in 10 chance that diltiazem really is at least 5% better. It's kind of spicy, Chat. I like that. Well said. Now, there is, I have to admit, no getting around the inconvenient fact that this study had a small sample size. And that's not a dig at the authors. You do the research with the data you have, not the data you want. But that small sample size is exactly why a Bayesian approach here has value. Rather than throwing up our frequentist hands and saying no difference because p-values, we can report the probability of seeing a meaningful difference based on this data. The small sample size does show up. It influences what's called the credible interval around that probability. Now, in this back of the envelope calculation, that 95% credible interval goes from negative 1.1% to 26%. Now, It's important to understand a credible interval in Bayesian statistics means that there is a 95% probability that the true difference lies within this range, given the data and prior assumptions. Now, this is different than the frequentist 95% confidence interval that we see all the time. Now, this is a misunderstood concept, and God knows I have certainly misunderstood it. A confidence interval means that if we repeat an experiment 100 times, 95 of those intervals would contain the true effect size. It does not, as I have been guilty of thinking too, it does not mean there's a 95% chance the true effect lies within the interval in one study. Now, that probably seems like a distinction without a difference to you. It just means that Bayesian credible intervals are often more intuitive for clinical decision-making than frequentist confident intervals. In other words, the credible interval is asking the question that we really want to know. So, the credible interval here suggests that while there is a small chance that adenosine might be a bit better, maybe even up to 1% better, most of the probability distribution is on diltiazem's side, and there's a potential benefit as high as 26.3%. Now, if you happen to be watching on YouTube, you're going to see a graphic that shows a curve with the majority. It's right over there. The majority, 89% in fact, of the curve showing a benefit with diltiazem. Now that we've fallen to the bottom of our deep Bayesian rabbit hole, the point I'm trying to demonstrate here is that while this isn't proof of anything, because again, just back of the envelope math, I do think it is a rather compelling example of how Bayesian reasoning can provide more nuanced insights than traditional p-values alone. Now, assuming that we climb back out of our nerd holes, what do we actually do with this stuff? So what, Jeff? How is this going to change my practice? Well, I have to admit it isn't going to change my practice, but that's because I already wrote a diltiazem first approach for stable SVTs. That's our approach here in Fort Worth. It's my clinical approach. I do think, though, that the evidence here provides additional support for my practice. In other words, told you so. So I appreciate this. Thanks, y'all. However, for anybody else out there who is still using adenosine as first line, maybe because ACLS says so, this study and a Bayesian interpretation offer additional information to help guide your practice. Now, I'm not saying you should change it. I'm just saying you should take a more nuanced view than just relying on statistical significance in ACLS guidelines. So if you suspect the point of this podcast isn't exactly limited to adenosine and diltiazem for SVT, well, you're right. I hope the one thing you take away from this episode is that not statistically significant does not mean no effect, and it doesn't mean not clinically important. And I hope you also take away that Bayesian methods can help us move beyond rigid p-value thresholds to make more informed clinical decisions. Now, as always, I welcome your comments and your thoughts. And again, I ask real statisticians out there and methodologists to email me and tell me how I got this completely wrong. From my colleagues at Baylor, Scott and White, and especially the medical students at TCU who did the hard work of this analysis and had the perseverance to stick with it through publication, I say strong work and thank you for your contribution to the literature. Great job, y'all. Well, that's what I have for you. Thank you for listening. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Firedog production. Visit flightbridgeed.com for more information.